So the objectives of my talk are, I'm going to discuss the value of CMR in evaluation of cardiomyopathy, mainly the question, what is going on in the myocardium? Then we are going to speak about why there is a cardiomyopathy. How does CMR help you to know why there is a cardiomyopathy? And finally, how does it help you with the how? How do you determine the prognosis as well as the treatment? So let's first discuss about how CMR helps with what is going on in the myocardium. So we all have seen this. CMR remains the gold standard method for evaluation of LV and RVEF. And I think for RV, it's particularly useful in the congenital heart disease. But I think when it comes to what is going on in the myocardium, if there is any abnormality in the myocardium, CMR is the test of choice. It also can tell you about the valvular function. And by combining all this, it can tell you if there is an abnormality in the myocardium. Going on next, we are going to speak about how does it help with the etiology of myocardial disease, why there is a cardiomyopathy once you have determined with LVEF, that there is a cardiomyopathy. So of course, CMR serves at the virtual biopsy of the entire heart, and this can be done effectively using different sequences within the MRI, which is T1 mapping, T2 mapping, a measure called extracellular volume measurement, and then finally the late gadolinium enhancement. So with various patterns specific to various diseases, you can identify what exactly is the cardiomyopathy going on. So I think what's important with CMR is it has these tissue characteristic for ischemic cardiomyopathy or ischemic myocardial damage, and then non-ischemic myocardial damage. So I'm going to show you some cases where that is apparent. So this is an example of ischemic cardiomyopathy. So on left side, you have a lateral myocardial infarction. And as you can see, with the myocardial infarction, the abnormalities, the late gadolinium enhancement starts at the subendocardium, and finally it extends into the transmural fashion. And right here, on the delayed enhancement, you can see this bright scar in the lateral myocardium. So that's the evidence that this patient has lateral MI. If we look at just comparison with tissue and delayed enhancement, again, delayed enhancement can be in transmural fashion in the coronary distribution, and you can see the comparison with the tissue. There are a few things that we should remember. So ischemic cardiomyopathy with abnormal EF. If you are calling a patient ischemic cardiomyopathy with abnormal LVEF, it's essential that that patient has fibrosis in form of myocardial infarction. The second thing is, regardless of whatever the clinical history of MI is, absence of fibrosis on the CMR accurately rules out ischemic cardiomyopathy. And why this is important is because, as we were earlier discussing about viability and revived criteria, if you're naming a patient ischemic cardiomyopathy, then you may feel compelled to open up or revascularize that patient, and that may not be true if there is coexisting non-ischemic cardiomyopathy. And then there is MINOCA, which is myocardial infarction without any coronary artery disease. And then also, it's important to remember that just presence of coronary artery disease does not indicate the patient has ischemic cardiomyopathy. So right here, you have a true ischemic cardiomyopathy. So this is a patient, okay, it's not playing. This is a patient with anterior myocardial infarction with LAD territory, but there are some examples from this paper that shows you how coexisting cardiomyopathy can be present. So here is an example of true dilated cardiomyopathy. Here is an example of CAD where you see the scar in the ischemic fashion. You can have dilated cardiomyopathy just with a small little scar because there is a bystander CAD. You may not have any scar, but you can have severe CAD, or you can have scar without any coronary obstruction. And then finally, you can have ischemic heart failure without any infarction. So it's important to keep all these categories in mind that two things may coexist. You can have severe obstructive CAD, but you may not have scar or vice versa. So of course, this is the paper that is widely cited in the CMR literature, but basically it's all about the pattern recognition. So on the left side, you have ischemic patterns, and then on the right side, you have non-ischemic pattern, and I'm going to show you some examples. So non-ischemic pattern can be epicardial, mid-myocardial, it can be patchy, and it can be in subendocardial fashion. It just doesn't have to follow the coronary distribution for you to call it a non-ischemic scar. And then these patterns are, of course, disease specific, and that's why you identify what kind of myocardial disease patient has. So let's look at an example of hypertrophic cardiomyopathy. So as you can see, hypertrophic cardiomyopathy is characterized by really thick myocardium, and then you have really patchy delayed enhancement in the hypertrophic segment. This is an example of hypertrophic cardiomyopathy. Concentric hypertrophic cardiomyopathy, you can have delayed enhancement at the junction point, and then there is patchy delayed enhancement. And there are a few things that are important to remember. So it's very common to have delayed enhancement with hypertrophic cardiomyopathy. In fact, 50% of patients with HCM will have some sort of fibrosis, but it's only when this fibrosis exceeds more than 15% of the total myocardium, it's considered significant, where it makes a 2B criteria for ICD implantation. On the right side, you have some data from the HCM registry, where they showed that actually the patients that are genetic positive, that have sarcomere mutation, they're more likely to have more fibrosis on MRI, but they may not have all the obstructive features, while patients that are sarcomere mutation negative, they tend to have more obstructive features with LVOT obstruction, but they may not have that much fibrosis. Oh, this is a case I borrowed from a colleague, but right. Can you play can you play on the video? These are really good images. Yeah, perfect. Thank you. So this is just to show you that every LVH on echo looks the same, but on MRI it has different characteristics. So this is a patient with Denon's disease, and you can see that there is quite a bit of LVH, and I personally would have called this some form of hypertrophic cardiomyopathy on echo, but on MRI you can see that there is extensive delayed enhancement, and this delayed enhancement is sparing the septum, and the sparing of the septum has been associated with Denon's disease. Of course, this patient got explanted because this was a young patient, and after transplant, this diagnosis was confirmed. So this is a very different LVH that you can see on MRI. Then, of course, cardiac amyloidosis would have patchy delayed enhancement, or would have this feature where we are not able to null the myocardium after giving the gadolinium. It's a technical term, but basically it's very different than any other cardiomyopathy in short form. And this is how we are able to diagnose amyloidosis. Sarcoid can be very patchy. So, keep messing this up. Look at the tissue specimen of sarcoid. So you have really patchy fibrosis on the tissue specimen, and similarly on MRI. Sarcoid can go anywhere. It can be in subendocardium, it can be in mid-myocardium, or it can be transmural. So that's something to keep in mind. T1 mapping and ECV can be very useful in clinical practice. So there are some disease that like amyloid or myocarditis or some cases of HCM will have higher numbers when it comes to T1 mapping and extracellular volume, while Fabry's disease or iron deposition cardiomyopathy may have lower numbers. So it really helps with the clinical practice, combining with other sequences what exactly the patients may have. Dilated cardiomyopathy, we just had an extensive discussion on left ventricular arrhythmogenic cardiomyopathy, but dilated cardiomyopathy also can have this ring-shaped delayed enhancement because of the genes that are shared by arrhythmogenic cardiomyopathy and dilated cardiomyopathy, and truly a complex disease when it comes to management. I have few slides on myocarditis. This is a clinic patient of mine with COVID myocarditis, extensive LV and RV dilatation. And you can see that again, keep messing up. You can see that there is high T1 and T2 mapping, and then there is lots of delayed enhancement in the entire LV. probably in the ring-shaped pattern. So myocarditis, we diagnose myocarditis by using Lake-Lewis criteria. So not only there is myocardial edema needed, but there also has to be non-ischemic injury pattern, and then there are supportive criteria like pericarditis, etc. So follow-up of myocarditis, typically once patient have late gadolinium enhancement on myocarditis, generally we like to follow up these patients. And if on follow-up there is no scar, that patient has excellent recovery, but then patients can also have persistent scar. And these are the patients that should undergo, further evaluation for any sort of genetic cardiomyopathy. So this is the paper that was published in JACC, and it showed actually that it was the mid-wall septal pattern of late gadolinium enhancement that was shown on follow-up myocarditis patient that was an independent predictor of cardiac events. And a lot of these patients actually have genetic cardiomyopathy, and perhaps that's why their events are so severe. And that actually was shown in this paper. So there has now been many papers, but now we know that myocarditis can show up as the hot face of arrhythmogenic cardiomyopathy that Dr. Jagia just talked about. So it's very important to remember that myocarditis can be the first manifestation of left-sided arrhythmogenic cardiomyopathy. So this is a patient of mine, again, a very young lady with PVC, and this is a case of left-sided, biventricular, does not play. Biventricular arrhythmogenic cardiomyopathy with a ring-shaped delayed enhancement. So this patient had multiple myocarditis before she came to us, and her manifestation truly first was with myocarditis before she presented with arrhythmogenic cardiomyopathy. So what I've shown you is how CMR with different sequences can be useful to determine what disease pathology the patient may have, depending on late gadolinium enhancement, depending on mapping values, depending on edema, cine imaging, etc. So finally, what we're going to discuss is prognosis. How does it help with prognosis? So this is, if you take patients that underwent cardiac transplantation, 8 to 21% of the patients, clinician made mistake on final diagnosis. So patient was given one diagnosis, but at explant, they found that patient had sarcoid, for example, or something else that could have been fixed, for example, Chagas disease. So what we know is MRI, when you diagnose a patient correctly with an MRI, not only it helps you with making the correct diagnosis, but you can also target the specific treatment, and perhaps a patient can avoid a cardiac transplantation. So it's very important to remember to use CMR for disease-specific treatment. So take-home points are CMR remains to be high sensitive, gold standard for detection of abnormality in the cardiovascular system, including myocardium and pericardium. It's important to utilize all the CMR sequences to diagnose and prognosticate the patients correctly when patients present with cardiomyopathy. And it really truly serves as the virtual biopsy of the entire heart and can help us with a disease-specific management of patients. Thank you.